Hello, everyone, and welcome to the ROSA Worldwide Webinar Series. My name is Mike Reed. I'm the Chief Scientist at ROSA, and I'll be your moderator today. I would ask that you check the ROSA website for upcoming webinars. We have another one coming up in December. I would also ask during today's presentation, if you are interested in submitting a question to the presenter, we'll be answering questions at the end of the presentation. You can enter questions by clicking on the Q&A tab at the bottom of your screen and entering the question. Today is going to be about a 15-minute presentation, so I would suggest if you have questions to come up with them early so that we have time to get those in for the speaker to answer them. I would also ask if anyone in the audience is interested in being a speaker in an upcoming webinar, please submit your email and interest in the Q&A tab as well. We're always looking for new speakers, and if you'd like to share your work to a wider audience, we would love to help with that. So today's speaker is Dr. Alvaro Ruiz Martinez. He's a senior modeler at ROSA, and he has 12 years of experience in computational and modeling experience related to mechanical, chemical, and biological systems. He's developed models focused on immuno-oncology, biopolymer assembly, and pharmacokinetics and pharmacodynamics. Dr. Ruiz Martinez received his PhD in mechanical engineering from the University of California at San Diego and his postdoctoral degree from Johns Hopkins University. So we're going to play the recording of his seminar, and Dr. Ruiz Martinez will be live to answer questions afterwards. Okay, Heather?
Hello, everyone. Today, ROSA is presenting an accurate model of ACTH and cortisol dynamics for Cushing's disease treatment. First, we'll start with an introduction, then with the description of the HPA-axis PhysioPD platform that ROSA has developed. Then we'll describe the calibration process of this platform, the creation of healthy and Cushing's disease virtual patients. Then we'll show results of implemented tests in the platform CRH and dexamethasone tests that we used to check if the platform was properly developed. And finally, some conclusions. Now, ROSA has developed a PhysioPD platform to model the effects of Cushing's disease on the HPA axis. Cushing's disease is a rare condition that results from having too much cortisol in blood. The most common cause is a pituitary non-cancerous tumor secreting a hormone, ACTH, which causes increased secretion of cortisol. The hypothalamic-pituitary-adrenal axis, HPA axis, regulates cortisol production. The biology and potential treatment of Cushing's disease have been recently reviewed in different publications, and the biological pathway regulating cortisol production has been modeled to analyze the effects of chronic stress, psychiatric disorders, and depression. Here, in this project, we propose a model that represents the HPA axis dynamics and the effects of Cushing's disease. ACTH and cortisol, hourly fluctuations, and daily oscillations are accurately captured when compared to previous models. In terms of the scientific background, we are going to focus on 4 species that come from a model that we took as a reference. The reference is here, Bangsgaard and Ottesen, 2017. The 4 main species are CRH, ACTH, cortisol, and circadian rhythm. Now, CRH is a corticotropin-releasing hormone that is released from hypothalamus and stimulates the synthesis and release of ACTH in the pituitary. ACTH is a hormone that is transported to the adrenal cortex, stimulating the synthesis and release of cortisol. Finally, cortisol feeds back by inhibiting the synthesis of CRH and ACTH. The circadian rhythm in ACTH and cortisol is synchronized by the suprachiasmatic nucleus. Now, we are going to describe the platform the original approach from that paper and the changes we have to implement to make it work for our purposes. The platform main elements are here in pink. We have CRH on the left, we have ACTH on the right, we have cortisol at the bottom of the figure, and also we have circadian rhythm here on the left. Now, to this structure, we added we added tissue mass. We had corticotroph mass in light blue on top of the figure, and adrenal mass, having an effect on ACTH production and cortisol production, respectively. And then we added other species, we added outcome measures and drug hormone treatments, and not all of them are represented here in this figure. Now, when we compare, when we use the model, we realize that the original calibration and even a posterior calibration published in 2022 were not fitting the data the way, the best way possible. And we realize also that the best way to fix that or to improve that was not about changing the equations, and it wasn't about using different data. It was more about using data differently. And with that, we mean that the data was 24-hour data from Bangsgaard and Ottesen paper. But what we notice is that if we use that data, we assume this data from a healthy patient shows the ACTH and cortisol levels of the 24 hours, but also if we assume ideal conditions, these could be data points for the second day and the third day and so on. We could use a 72-hour data set by repeating the original 24-hour data set 3 times in a row. By doing that, and also by assigning more weight in the calibration process to the high concentration data points, the peaks of these oscillations, because we wanted to capture that much better than the low oscillations. Well, by giving more weight to those data points, we also improve the fitting of these peaks, as we can see in these figures, in both cases, in both species. And we also reduce the effect, by doing that, we reduce the effect of inconsistencies between data points at 0 hours and at 24 hours. Again, in ideal conditions, those data points will be more or less similar. If they are not, then it's really difficult to calibrate the model in a way that keeps a stable pattern after 24 hours, because that difference can become much larger after 24 hours of simulation. Now we can see the real difference when we run the simulations with all models, with the other previous models and our model for more than 24 hours. We represent here 5 cycles, 5 days of simulation, and we can see like the first day, similar to what we saw in the previous slide for cortisol and ACTH, but then over time we see that in orange how our model is able to keep a stable pattern and the main fluctuations over time. However, for the other models, for the other calibration approaches, we lose the oscillations, we lose the fluctuations and daily fluctuations very quickly in a matter of days. So these are not models, or at least the calibrated approach don't work. They don't work for more than 1 day. Now, in terms of virtual patients, as we show, we already have data for a healthy virtual patient, and then we created a Cushing's disease virtual patient. For that patient, we needed to implement the effect of a tumor. Right here, we can see in the physio map in the center of the figure, the production of ACTH is affected by the presence of a tumor. Now, the way we implemented that for this virtual patient was by including a constant rate of ACTH production and a CRH-dependent rate to capture these tumor effects. Then finally, after these virtual patients, we implemented the dexamethasone test. That is a test that is run in clinical conditions, clinical setups, and a CRH test. Now, these tests help to identify the source of excess of cortisol and ACTH, respectively. Both are used in the diagnosis of Cushing disease. Now, the platform, as we explained, defines a healthy and Cushing disease VPs, but based on literature data. The healthy VP, we already had the data. That data shows circadian and ultradian rhythms and concentrations that are appropriate, hormone concentrations in plasma compared to real data, as we can see here at the bottom, at the table at the bottom, where we compare the concentrations at 8 a.m. for healthy VP compared to the expected range in healthy subjects taking defined based on literature data. For the Cushing's disease VP, we have also average values. We ran simulations once we calibrated the VP, and we got over 24 hours, we had these average values for cortisol and ACTH that are within the range of values expected in Cushing disease patients, range of values that are defined, of course, based on literature data. Finally, we also define salivary cortisol levels that our simulations show that are in agreement with the data. And this salivary cortisol basically is correlated, according to literature, is correlated with cortisol in plasma. Now that the platform was ready, was calibrated, and the VPs were created, we implemented and ran CRH and dexamethasone tests. Now the CRH, or corticotropic releasing hormone test, stimulation test, it, as we mentioned, identifies the source of excess ACTH in ACTH-dependent Cushing syndrome, because pituitary tumors tend to be sensitive to CRH stimulation. For the dexamethasone suppression test, it measures if cortisol secretion by the adrenal gland can be suppressed, and it is used to help assess the reason for an excess of cortisol, and can differentiate between different causes of excess cortisol, such as ACTH secretion by the pituitary or an adrenal tumor. Now, these are the results for Cushing disease VP for the CRH test for ovine, not for human. We have data, ovine data, and the plots represent the Cushing disease VP results, but on the table we have also results for healthy VP, and in both cases the results match the data. Now, what we wanted to capture here was first we implemented the test where that we can see here in the CRH plot on the top left how at 15 minutes a dose of CRH is administered, different doses from 0.5 micrograms per kilogram to 2 micrograms per kilogram. And that dose, CRH dose, of course, increases ACTH levels on the right and increases cortisol levels here at the bottom left. Now, if we look at the concentration, the maximum concentration of ACTH and cortisol for the 1 microgram per kilogram dose, IV dose, that's what we have here in the table for healthy and Cushing disease VP, the first two columns. And we see that these values are within the range of values expected according to literature for both healthy and Cushing's disease VP. Now, these results, although we didn't use human data, we show a qualitative example here of what will happen in concentrations in human by applying some allometric scaling. So potentially the platform can predict these fold changes in humans if we apply the proper allometric scaling. Then finally, we implemented the dexamethasone test. Basically, we administered a dexamethasone dose at 23 hours of simulation. And what we expected, this is based on based on the protocols from literature, how the way we implemented the administration and the way we represented, the dose, the amount of dose, etc. This is according to what is in the literature. And we saw that we were able to capture for cortisol levels, as we can see here at the bottom right, the peak concentration, in particular the 8 milligram dexamethasone. We have data for the peak and also for the inhibition of cortisol. We see that the cortisol has decreased for the dark blue line, for both the pink one and the dark blue line, but the dark blue line is the 8 milligrams dose. We see that after around 10 hours at 9 a.m., according to this data, the inhibition of cortisol was still more than 50% with respect to the initial value at 24 hours, where the dexamethasone dose was administered. So in this case, we were able also for this test to capture what is expected according to the data. Finally, some conclusions. The ROSA PhysioPD platform is a reliable tool for development and testing of HPA axis therapies. The model simulations match published single-day clinical data and remain stable and accurate in long-term scenarios. The platform simulations are in agreement with results reported in literature. They replicate a healthy and a Cushing disease patient, and both VP's responses to CRH and dexamethasone tests match clinical data. So finally, we can say that a variety of CD treatments can be implemented for therapy development or predictive purposes in this platform. Drugs targeting ACTH and/or cortisol production, tumor removal, adrenal glands removal, or inhibition of their effect on cortisol production. Thank you for listening.
Thank you, Alvaro. And if you wouldn't mind unmuting, we have a couple of questions here from the audience.
Okay.
First question is, you showed one healthy and one Cushing's disease virtual patient. How would you go about, given the fact that we know patients are variable, how would you go about creating an alternate virtual patient with Cushing's disease? And how might you expect a different virtual patient to respond differently to the types of therapies people might use?
Thank you for the question. So yeah, the model, maybe I can share the screen and show in the slides. Sorry. Sorry. Let me just access this. So I'm going to show the physio map that we have. Yeah. So, for example, to create new VPs, if something that we saw in different publications, in particular the one that we use as a reference for the model, is that obviously each patient has different circadian rhythm, right? Different daily oscillations and hourly fluctuations or ultradian oscillations. So, for example, here in the model, if you want to capture, you have data like we have for this particular healthy VP patient or the Cushing, well, for the whole healthy VP, we have the data. You can take the data from the Cushing's VP and maybe calibrate the parameters in the circadian rhythm function that we have here from the model to capture those fluctuations. Also, there are other parameters like the production of these different species, ACTH hormone or cortisol, that can be adapted to match the data of each patient. Sure.
Okay, so would you vary those parameters independently, or would you look at actual patient data perhaps to get covariations? Because you might expect certain things to go in parallel and certain things to go, in opposite directions and things like that.
Yeah, yeah, it's quite variable. In the papers we use, we have, for example, data from different patients, and in fact, these models were fitted per patient
To
because
actual
they
patients.
can
Okay.
be, yeah, actual patient, because the difference can be quite significant, and even more with Cushing disease, not just for the healthy patients comparing to each other, but also across Cushing BP patients. Yeah, they can vary a lot.
Okay.
Mhm.
Thank you. Can you speculate on what possible treatments or interventions in this system that this model could evaluate as potential therapies? And this was done as a client project, so obviously don't want to discuss the specifics of that project. But if you could speculate on some of the other pathways that are things that seem like they might be ways to influence the system.
Yeah, I make a brief summary here and in the last slide, and then I can show again the diagram. I give some examples. For example, if we are targeting the ACTH or cortisol production or both, if we are removing the tumor also, because as we explained in the presentation, we have the tumor implemented in the model or the effect of the tumor, and that can be that can change depending if you want to treat that or even remove it physically. You can represent that in the model. And also because we added things, we added the adrenal glands, the corticotroph mass, we can also represent that, treatments that are targeting that. We have all those species here we can see. And you can represent, like we did, for example, with dexamethasone. We can see in orange here color. This is just for the text that we run, but we can implement, like, for example, the PK, the pharmacokinetics of a drug, and then see the effects on a specific target, like ACTH production, cortisol, etc. So,
Okay. So, this model was clearly designed as a fit for purpose model to answer a pretty specific set of questions. If you were going to ask other questions, what types of biological elements would you be interested in adding to the model, or what kind of additional, let's say, published therapies do you think would be of interest if we were going to expand this model to ask a different set of questions?
yeah, so we didn't explore much, and I think that what I would suggest is to explore more, like in particular, long-term effects of the adrenal mass and the corticotroph mass effect on the production of the production of ACTH. We implemented. We even we can see here calculated some kind of long-term effect, like we have here, for example, on the top left, CRH AUC, this area under the curve, or obviously the accumulated effect of CRH on the production of corticotroph mass, how increases the mass of corticotroph increases, and the same with ACTH here on the right. So, for example, that is very, very important, and we did some work on that, but I will explore that further in this model. Yeah.
Okay. Interesting. Okay. Well, those are the questions that we have for today's talk. So I'd like to thank our speaker again, Dr. Alvaro Ruiz Martinez. I'd like to thank the attendees for joining us. And again, if you are interested in presenting in an upcoming webinar, we are interested in getting additional speakers. So feel free to contact us on the ROSA website, and we'd be happy to discuss scheduling a webinar with you. So with that, I'm going to let you go, and have a nice day, and we'll see you next month in the webinar series. Bye, everyone.
Thank you.